How do you know? Well, baby blues happens in like 70 to 80% of moms get it.
Right.
It's very, very common, yeah?
Yeah.
So
So not everyone gets it.
not everyone gets it.
Oh,
Not everyone gets it.
okay.
But it's pretty high. 70
Yeah.
to 80% of women
That's a lot.
get it. That's a lot. And it happens within a couple of days of birth, and it goes away within 2 weeks. So it goes away.
Right.
Yeah. It's very mild anxiety, teariness, feeling a bit blue, literally blue, but it goes away. And it doesn't impair your ability to care for yourself. Like, you're still able to have a shower, eat food, care for your baby, receive guests, smile. You're still able to function, and it goes away.
Hello, everyone, and welcome back to No Place Like Home. I am Larissa, and I'm here with the beautiful Jess.
Hello, everyone.
And we have the incredible privilege of having Dr Edna Lekgabe back with us for another episode. If you haven't listened to the previous episode with Dr Edna,
Please don't.
no, go back and listen. Yeah, it was fantastic and really informative. So we're going to continue to pick up where we left off. First question, when do you cross the line from baby blues into postnatal depression or anxiety?
A lot of people ask that question as well. How do I know? Because everyone talks about baby blues.
Yeah.
It looks quite similar. Same, but different.
Yeah.
So the difference is, how do you know? Well, baby blues happens in like 70 to 80% of moms get it.
Right.
It's very, very common, yeah?
Yeah.
So
So not everyone gets it.
not everyone gets it.
Oh.
Not everyone gets it.
Okay.
But it's pretty high. 70 to 80% of women
That's a lot.
get it. That's a lot. And it happens within a couple of days of birth, and it goes away within 2 weeks. So it goes away.
Right.
Yeah. It's very mild anxiety, teariness, feeling a bit blue, literally blue, but it goes away. And it doesn't impair your ability to care for yourself. Like, you're still able to have a shower, eat food, care for your baby, receive guests, smile. You're still able to function, and it goes away. Now, and it only shows up postpartum, so it's baby blues. So it doesn't show up before. Whereas perinatal depression and anxiety shows up during pregnancy, after pregnancy, anytime. It shows up any of those periods, yeah? And when it shows up a bit more persistent than baby blues. When it shows up and it lingers. It doesn't just hang around for a couple of weeks. It stays on. It's there consistently, and it's intense. So it impacts your life. It impacts you. You're unable to potentially hydrate yourself or eat well. You're unable to relate to your partner and your friends. You're socially withdrawing, unable to bond with your baby. Like, it's hard to feel something, even though you know you're meant to feel something. Then there's that whole self-judgment about not feeling anything and feeling guilty. So if it's depression, hopeless, helpless, worthless, guilty thoughts, potentially suicidal ideation, that stuff doesn't show up in baby blues.
Yeah, okay.
You know, this is more unique to depression. Anhedonia. I don't know if you guys know anhedonia. Anhedonia is where you lose interest in doing the things you enjoy doing. Real Housewives of Beverly Hills doesn't cut it anymore. Like, you're watching it, it doesn't tickle you that way anymore. You know, you don't.
So nothing's filling your cup.
Nothing.
What's
nothing.
it called?
Anhedonia.
Never heard of
Yeah,
that.
it's like you just don't feel like. You just don't feel
It's almost
like
like an apathy towards everything.
about things that used to bring you joy, you know. If I'm to sit down in front of Real Housewives of Atlanta, I'm not having fun, I know something is wrong. What's wrong, you know?
Yeah.
It's not bringing you joy. You're socially withdrawing. Your appetite has changed. Your sleep's disturbed. Or if it's anxiety, you're ruminating. Your mind's racing. It's racing. You can't focus. You can't concentrate. You're restless. You're irritable. You're grinding your teeth. You've got headaches. You've got irritable bowel symptoms. And in some cases, the perinatal depression and anxiety also encompasses postpartum psychosis.
Right. That
It's
was going to
clumped in
be
there.
another question. So aside from postnatal depression and anxiety,
Yeah.
what other
Yeah.
mood disorders
There's
may
OCD would be a big one too.
Yeah, absolutely. But in terms of still, differentiating between baby blues. Yeah. So baby blues shows up after birth within 2-3 days, and it's
that's
gone
just the
within 2
hormonal
weeks.
come down, right?
Yeah,
Like I don't want to say just, I don't want to minimize it, but it's
absolutely.
a result of that immense high that you were on while you were birthing, and then the hormones leave and
The lack of sleep, the reality hitting you. Oh my God, what have I done?
my life has been flipped on its head.
I remember saying
That transition.
so much.
It's
What have
this.
I done? Yeah.
My life is over, or it's huge. Yeah, your relationship with yourself changes. Your relationship with your partner changes. Your mom, dad, everyone. So that huge. It's a roller coaster. So it feels like that. It's like you're crying one moment, next moment you're not. You're able to smile, keep moving, and care for
You can get out of a funk quite easily.
quickly.
Yeah.
Depression you can't.
Yeah.
It just lingers. It lingers and lingers and lingers, and affects everything. Anxiety is the same as well. So it's the severity, it's the duration, it's how it impacts your life. That's the difference between them. Now, other conditions, so there's so many more conditions that can show up postpartum.
Is psychosis is that a progression from postnatal depression and anxiety, or is it something completely separate?
It's a completely separate entity. But it also is quite similar. Yeah, it's in terms of the symptoms that you get, quite similar, but it is its own unique condition.
Okay.
But it can start off as anxiety
Okay.
and depression and roll into that.
Okay.
Absolutely. It's a devastating condition. It is just horrible. Fortunately, it doesn't happen frequently. 1 in 2,000 women get it.
Okay. I was going to ask, what are the statistics?
Yeah, 1 in 2,000, but I see a lot of it. Maybe it's because of the work I do.
Yeah.
But but it sounds like everyone knows somebody who's been affected by postpartum psychosis. It's a medical emergency. When it shows up, it's quickly get this person to hospital because the risk is too high. And usually the risk is harm to mom and harm to baby. So you need that person in hospital getting treatment, and when they leave hospital, they need intensive ongoing treatment. So it's the only psychiatric condition that's actually quite an emergency. So you have to get someone in quickly.
Right.
But it's hard to tell.
That was going to be my question. How do you know? How do you know when psychosis is setting in or happening?
Yeah. So it usually shows up within the first couple of weeks postpartum. It shows up in the first couple of weeks, and it shows up in the first couple of weeks up to about 8 to 12 weeks postpartum. That's the highest risk window. And the way it shows up, it's like an insidious condition. It's insidious. It's fluctuating. So someone looks okay, relatively okay, but then they're not okay for little brief moments. And when they're not okay, they're really not okay. They're disorganized in the way they're thinking, in the way they're behaving. Like, I'll give you an example. Mom folding clothes of a baby and putting it in the fridge. Bizarre behavior, having delusions of, false beliefs about something, something is wrong with the baby, and having really fixed
or someone's trying to hurt me and the baby. Or
and it's unshakable. Hallucinations, hearing or seeing things, that's harder to know because the person doesn't tell you, but partners usually tell me, I find her talking to herself in the room. She's having conversations with someone. I don't know who she's talking to. And partners can't tell because it's so fluctuant. They're okay one moment and the next moment they're not. And they can be quite elevated, like look happy, look really energetic, energized, cleaning the house, rearranging things, feeling really productive. But then they can look quite depressed. So that's why it looks like a mood disorder, because it's like elevated, depressed, disorganized, talking really fast.
It's the high and the low and nothing in between.
It's just like fluctuating. And that's how it starts, and then it gets more and more, and the risk is really high. So it's really hard for family to pinpoint that when it's happened. So when I do see it, I can tell very quickly when I see it. And partners, it's usually a shock to them that I've said that this is postpartum psycho. And they're like, oh, I just thought she was anxious. That she was just worried. That's what you meant by, is it anxiety? Is it depression?
Yeah.
It's got all of those features, but it's its own entity,
Okay.
you know. And the risk factors for it are family history of psychosis, your own history of psychosis, first-time mum. It's overwhelming. You try and do everything a perfectionistic. You're really working really, really hard, really, really hard, and no sleep.
No,
Zero
it's
sleep.
just
I know.
torture.
It's horrible, and
just-
treatment's available for it if you get it really quickly.
Yeah, and I guess that's such a tricky thing because the person who's experiencing psychosis won't know.
They don't know.
The person who's witnessing it
Doesn't know either.
thinks maybe they're having a manic episode,
Or they're just anxious and
they're really
worried.
anxious or paranoid. But
Paranoia is definitely a symptom. Paranoia. They become super paranoid about stuff.
yeah,
Yeah.
and I guess knowing where to draw that line and knowing when, okay, my partner's acting really paranoid, but everything's okay, versus my partner's acting really paranoid. I think this is psychosis. You know, most people, the general population don't know how to
Nobody
distinguish the
knows.
difference.
Yeah.
And when to seek medical attention.
And sometimes the bizarre behavior is almost, explainable. Like, do you know what I mean? Like
the
some
hormones, the sleep deprivation.
You haven't slept for a while. You're going crazy, girl. Like, go and get some sleep.
Yeah.
Correct. And sometimes the psychosis is related to what's happening for them. So, for instance, becoming really obsessed about how much milk the baby's getting and becoming really disorganized about it, in the way they're doing the maths and becoming so focused on it and really driven by it. It becomes a real hyper-focused delusion almost. Well, it's delusional.
Yeah. And is there a way to stop symptoms progressing, or is it that once
You just need to get them in.
develops, it's a medical emergency?
Medical emergency.
Medication is
If they're
needed.
at home, they need to come in an ambulance, get assessed.
Yeah.
They need medication.
So is medication the only way
The
out?
only way. The only way out. The
And I
only way
suppose
out.
that's really scary.
brain's
for
on fire.
people. That's really scary for people, particularly if you're a partner seeing, you almost, I would imagine, don't want to feel like you're putting them in that place of like
course, yeah.
a psychiatric hospital or, it's daunting. Yeah.
It'd be so difficult to.
So difficult.
Yeah. So usually they'll come into a general hospital. Something's not right. Something's not right with the baby or struggling with breastfeeding. And then the emergency doctor will be like, something's not right. Something's a bit off. Can you come and see this mum?
Yeah, okay.
And it's so strange. Like the partner's there and they can't see it because of that whole, I can't,
It's just the new.
Yeah, it's a new norm. This is.
I guess, because the partner's life has also been flipped on its head and there's so much change and you expect.
Everyone's sleep
you would
deprived.
question yourself. You would
Correct.
think, no, my partner isn't experiencing psychosis. They're just sleep deprived.
They don't even know the word sometimes.
Yeah, of course. Yeah.
The condition.
Yeah, or the condition. It's very rare for someone to say, oh, yeah, I know what postpartum psychosis is. No one does.
But this is, when we talk about preventative care, this is the sad thing about that I feel we are dangerously close to normalizing postnatal depression and anxiety and all of these symptoms as just a normal part of, this is what happens. And it doesn't need to be like that because there are other countries that have very different rates of postpartum mood disorders statistically as opposed to a lot of Western countries. Yeah. And there's a reason for that. And we need to stop thinking that this is just
part of the norm. Yeah, it's not.
This is just normal.
It's not.
Because then we start to miss these signs because we're normalizing behaviours that are not normal.
Yeah, exactly.
And then they're going longer, are they?
Longer and more dangerous.
Yeah.
Longer and more dangerous.
And that's when harm can occur.
Yeah,
to the
harm
mother, the
to
baby, or both.
Or both.
Yeah.
Yeah.
Devastating harm. Yeah.
horrible. And, sometimes harm only comes to baby and mom survives. How
Oh.
does mom,
No, and
How
then
do you
that
how do you,
reconcile that?
how do you ever come back from that?
Yeah.
And for some moms that have gone there and come back, they remember what happened. They remember, even if there's no loss of the baby, but they remember being in that state. Frightening.
So does the brain remember that
Parts of it.
parts of it?
Yeah, remembers parts of it, not exactly everything, but because it's almost like a delirium. It's like delirium is an acute disturbance of behavior that can occur in people, and memory's not laid down properly. So a woman can remember some parts of it. It's really, really sad when they
Which
can.
would then create a trauma of it.
Exactly.
Then you have to go through and digest and work through that.
So this is what I mean by after treatment and they go home.
Yeah, it's not
very
just
close.
go home.
No,
You're
just go
okay
home and
now.
you'll be okay. Follow up with your GP. No, it is intense follow up that's needed because the risk is too high still.
Well, this is sort of, we've had some occasions here at home where, we're seeing women after mother baby units and, it is we have a very stringent, entry requirement here, and there's a lot of conversations between healthcare professionals and teams but we often say, my God, if this woman hadn't have come here, she would have just gone home.
Yeah.
Like it just would have been okay. And yes, she would have had a plan and, but all of the factors that we talked about that support the recovery of nutrition and rest and care and
all that stuff has disappeared in the Western world.
It's
But
gone.
also, it's all good and well to have a plan, but actually being able to follow that plan is so difficult for people who are struggling,
Yeah.
It's all good and well to say, okay, fix your diet, okay, seek out support with friends, but when you're depressed,
You can't do any of
can't
that.
do that.
You need somebody else to do that for you.
Yeah.
And there
support.
would be a lot of shame around the after coming home from a mother baby unit, carrying that burden of shame then.
Yeah.
Like you don't want to be like, hi, I'm home, everyone.
No.
Like Anyway.
Not that anybody should feel shame if they are in a mother baby
Absolutely
unit.
not.
We're so glad that they exist and we, there's no judgment or shame for anyone who's suffering from any kind of mental illness at all. But
shame shows up for people.
the social stigma, unfortunately, is still there for a lot of people.
Yeah.
Yeah.
Absolutely. Absolutely.
I guess I could just ask you, say in a hypothetical sense, say someone is taking medication for something.
Yeah.
And they want to get pregnant, would they have to come and see you or their psychiatrist first to chat about whether that medication is safe to be taking while they're pregnant?
Best to do so.
Yeah.
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 Absolutely.
Because
And
I
not just-
imagine
Yeah.
sorry, what?
Not just psychiatric medication, all medication.
Yeah. And then I imagine there's also the question of like you can't just go off your medication.
Yeah.
You can't like that would be just as dangerous as
Absolutely.
continuing it potentially.
Correct.
Yeah.
Correct. So when it comes to medication chat, it requires really careful consideration and understanding what got you on this medication to start off with. Well, what were the symptoms? What was happening? How, what impairment did you have that led to you using this? Were you suicidal? Were you using substances, for instance, as a coping strategy because life was so bad, or you were not working, or you were unable to sustain? What was happening for you at that time that led to the use of medication? So you need to look at the level of impairment that you had when you made that decision, and understanding your condition is so important before you can even make the decision whether I come off it or not. Does that make sense? So if you know that that depression that you had back then was related to a intimate partner violence, which is no longer a part of your life. Potentially, and that was the source of where things were coming from. You were unsupported. You had no family. and things have changed dramatically.
Yeah.
Then then we can talk about risks of not being on medication versus risks of being
On
being
medication. Yeah.
Yeah.
So it's a delicate conversation. Yeah, it's a real delicate. It's
And
always,
it's so personalized.
I know it's so personalized. So it's so hard to say. All I know is, when do you consider medication? You consider medication when you have severe mental illness. When you have an illness which is life threatening, you have to consider medication. You have to think about, what's the risk of me not being on this medication if it's life-threatening versus the risk to the baby. You need to weigh them out. And everyone's different in the way they make the decision. I'm just there to support them and say, if you're going to make this decision, okay, if you're going to come off your medication, we'll do it safely. And then we'll put a plan in place that if things come back, we're back on the horse. Yeah. But coming off cold turkey, never a good idea.
No.
Whatever medication it is, like if you're on pain medication, don't come off a cold turkey because your pain's going to come back. You need to have a plan.
Yeah.
Coming off things slowly, have a plan for it.
And in a supported way.
In a supported way. Yeah. And if you're going to come off medication, think about, what else am I going to do to support myself? What lifestyle stuff? I can't continue having just a block of chocolate for dinner every night. I need to think, why not? Why not? I know, why not?
I wish chocolate had iron, B12, vitamin D.
Why can't they fortify it?
Why can't they fortify chocolate? Seriously. If anyone's listening, any chocolate
fortify
brands,
it.
come on, Loco Love.
So when is it you need medication? When you have severe mental illness, you need medication. You need to really think about the risks. When there's risk of harm, you really need to consider it. If I come off it, will that risk come back?
It feels like there's still a stigma around mental health medication and breastfeeding and all of that. What's your take on it? What's your...
It's always talking about the risks of treatment versus risks of no treatment. There's risks associated with all medication, Panadol even. Nurofen, all of it.
Panadol's not great.
No, and Nurofen's even worse.
Oh,
so in pregnancy especially. So it's about really, again, it's without being specific, like it's about
of course,
thinking about what are you on, and let's talk about the risks.
Yeah,
because there are some medications do have risks. We'll talk about the risks, the percentage of risks, and the percentage risk of you relapsing
of your
mental illness.
Yeah.
And if it relapses, what happens for you? For you? Do you stop eating? Do you stop going out?
Which then has other effects to your baby and to your health.
Exactly.
Ultimately.
Then you don't show up to appointments. You don't get antenatal appointments. You can't make it there. You're not working. You lose your job. You're then homeless. You're using substances. You're ending up in conflict with your partner.
It can go down so many.
So it's about really quantifying when you got on this medication, what was happening then, and it's if things haven't changed that much, it's probably going to come back. So it's about really having, whenever there's the medication discussion, and usually a lot of people come to me because they're on medication, they want to know, can I come off it? And I'm like, oh, that's $1 million question. Yeah. Can you come off it? I don't know. Let's talk about it.
Why do you think people ask that question? Why is there an eagerness to come off the medication?
I know.
Is it a social stigma thing?
Social stigma. And it's hard to know what you can't see what you're treating. Like if it's a broken arm, it's healing. If it's like a wound, you can see it. With, people say, oh, I got better. I don't know why. It's like,
the medication.
Do you think it could be the medication?
Yeah.
No, I don't think so. And you're like, okay. I'm sure the medication had something to do with it, but also other things. But it's about stigma, huge. Yeah. And also, I think there's bad press about medication,
Big Pharma cops a lot of bad press. And rightly so often, but also there are times, like medication saves lives as well. So
correct. Sometimes I see people that are on medication, which is way worse than the psychotropic medication they're on. And I'm thinking, why are you focused on this one?
Yeah.
You're on way worse. But because it's a physical health issue, that's not considered to be dangerous. Do you know what I mean?
Yeah.
Could be a rheumatological medication for rheumatology. It's like not even considered to come off that, or considered coming off. So it's really It's
Yeah, it's
complicated.
interesting, isn't it?
I know.
It's just the perception of what has been placed on
Yeah.
whatever the illness
Exactly. The stigma associated with that
instead
illness.
of, yeah.
Yeah. It's almost more accepted to be treated for something.
Yeah. I know that's certainly why I was never medicated and never have been, but I know that was certainly something that I held on to about, well, I don't want to be medicated because then
People
I
worry
must
about
be.
addiction as well. They get that,
And relying on it.
relying on it. I don't want
to.
to rely on it. I don't want to be dependent on anything. It's hard. It's very, very hard. It's a complicated question. So when people come with me with that question, I say, well, let's sit down and talk about, why we're on this medication to start off with and try and have an educated sort of discussion around it. Look at the risks versus risks.
Yeah,
And
risks
then
versus risks.
risks of not being on it and risks of being off it. Let's look at both sides of the coin, and whatever you decide, support it. Support it, and we'll do it safely. And you need to have a plan. If you're going to come off it, you need to have it. You can't be like, I'm just going to come off it. And
I'm just going to not fill my script this week and see what happens.
Yeah, see what happens.
Not a good
Not
idea.
good. It might be okay, but it might not be.
Yeah.
And
So if you do have questions, go to your healthcare professional.
Yeah, absolutely. And sometimes a healthcare professional, your GP, might not be able to answer it because the medications are quite complicated. Then you come and see me.
Yeah.
Then we can really talk about why we're on this and just talk about it. And sometimes family get involved in the decision as well. Partner get involved, and sometimes the opinions vary. That becomes really hard when one person wants it, the other person doesn't, because the partner's seen stuff.
How much the medication's helping, or doesn't know how much it's helping you,
or doesn't know. So either the partner's an ally or not. It's complicated. It's so complicated. But having a discussion is the most important thing.
Yeah. This is a slightly different. Well, same but different. I want to ask you one last question, the $1 million question, really, for us anyway. What are your thoughts on the current state of postpartum care in Australia?
Oh, Lord.
Yeah.
It's non-existent.
Yeah.
It really is non-existent, You go home and you're like, you'll see someone at some point.
Yeah.
If you're lucky, in a few days, and then they'll see you once or twice, and then you'll see your maternal child health nurse in weeks. You'll get linked in with a support group maybe at 8-10 weeks. There is no support.
No.
Zero.
Yeah.
Zero. What is the support?
What do you think needs to change? What would you like to see? How would you like to see it look?
As soon as a woman is pregnant, she
starts there.
I was saying this yesterday. Imagine if the council mothers groups, because I know there's private ones that are starting in pregnancy, but not everyone has the means to be paying for things like that. The council ones, because they're state funded, imagine if they started while you were pregnant. And you do a birth course and you learn about postpartum and you learn about filling your freezer, and you even get together with everyone in your group who all lives in your neighbourhood, and you cook together and you fill your freezer, and then you all have your babies, and you
already know each other.
You might not have
village.
You might not have the best connection with every single person in that group, but there's also a bonding that comes through the motherhood experience that it breaks down every other barrier.
Correct.
Because you shared in this experience of motherhood. And imagine a world where the mothers group started then in pregnancy, even if it's not until 34 weeks, 36 weeks.
Yeah.
And
but
then
you've got early.
You've got that support. And then when you start the mothers group, you already know each other. And I just think even that would make such a difference to people's experience, because it would be so much less isolating.
Correct.
Who do we speak to? Larissa Leone. Get on your get into your policy.
One thing at a time. It is. It's horrendous. It really is. We're just doing. We're not doing any preventative work or just
It's
we're just
all
dealing with the
yeah.
fallout.
Yeah.
Postpartum depression, anxiety.
Reactive, not
React-
preventative.
exactly.
Yeah.
We need to be at the beginning.
Proactive, not reactive.
Is that how you think we change the narrative, Dr. Edna?
Absolutely.
How do we
Starts at
do
school.
that? Yeah.
Yeah.
Did we know about this? And what it was and what it looked like. It's starting at school for girls and boys.
Yeah.
Everyone needs to be
This is the
aware
thing.
of
It needs to be the responsibility of both as well. It's not just a girl's problem.
No. Everyone. Yeah, it needs to start education. Education will free us all. Starting, right at the beginning, and then where do we intervene for moms when they're pregnant? As soon as early as we can.
Yeah.
Potentially at the 20 week. I say 20 weeks.
Yeah.
That's my magical spot.
I didn't want to get too early because I know people are busy and working and stuff, but I just think the sooner the better, really.
The sooner
if
the
you say
better.
20 weeks, I'm with you.
Yeah, just to talk about planning and what it looks like. 'Cause, some people don't plan.
No.
They don't know what to plan
Very
for.
few plan.
We focus on getting the bed, the cot, the room ready, the bag that goes to the
Pinterest
hospital.
nursery. I always bitch about the Pinterest nursery.
Oh my God, yes.
The baby
yes.
Nikes. Don't even get me started on baby Nikes.
It's like, what else are we doing? So it's hard. So I don't know.
It's not it's certainly not a one quick fix.
No.
It's very multifaceted.
It is. It is.
Yeah.
It starts, it would have to redesign the whole society as we know it.
Yeah.
Literally.
And
as we know.
the systems at the moment are big and they're strong. And so it's even really difficult to get in and amongst.
The system is sustaining itself in its dysfunctional way.
Correct.
It literally is sustaining itself in its dysfunctional state. It's like, we want to change, but you can't because the system is set up in a way that won't let change happen.
Yeah, which is precisely, when I started creating this, it was like, well, how do we create something like this within the system? And they're just the pushback and the shut doors and the pushback and the shut doors. So I was like, okay, well, I'm going to just go outside of it.
And just do it.
Yeah. And, but you've still got to have buy-in. Because the system has dominated the market.
The system has
and the narrative.
The propaganda.
The system is not serving women and birthing people.
Well, no, because we're sitting here having a discussion with a psychiatrist about all of the issues and the risk factors, and it is majority of the birthing population.
Correct.
Right? So
actually, all of them.
All of them. So where do we go to from there? Like that's our big problem. And what are we doing about it? I think that's, you can tell that's my frustration.
Well, home is doing something about it.
Sit with you.
Yeah. Home is doing something about it. Yeah.
We are. We're trying really hard.
Yeah. You're having women in this space. You're healing them.
Yeah.
This is preventative work that you're doing.
Yeah, I think
really
that's the key. It's the preventative work.
Yeah.
And there's so many amazing people out there trying to do their hardest in this preventative space.
But doors are shutting. But we just keep on opening them.
They are.
Build new doors.
Build new doors and windows and just...
Well, that's what I did. Yeah, I just went, fine, I'm going to go and build over here on my patch of land.
And we'll see. And I think that's beautiful because you're allowing women to have, to realize that they have a right to rest, to being cared for.
What now? We're allowed to rest?
I know.
What a radical concept.
Allowed to rest, put their feet up and be cared for.
Yeah.
How is that possible? It's like not used to it, but that needs to happen. I come from a culture where you have 40 days, 40 days of confinement in my culture where you sit there, you don't exit the house, you're fed, you're bathed, you are moisturized, you are bound. You are just
your only job is to rest and feed your baby.
And it's focused on the mom.
Yeah.
It's focused on the baby. It's like, Mom, you are the priority. Baby's brought in, baby's taken out. You are the priority. It's called Umul Bihis, which means you are helping the mom come out of where she was at. You're rebirthing the mom.
Rebirthing her.
Like literally, it's like, bathing her, feeding her, nourishing her. Baby will just get looked after, but it's about the mom. It's about the mom.
What happened? What happened to us in the West? It's a whole other podcast episode.
I was going to say.
We can get you back for
Oh
Dr.
my God,
Edna.
yeah. It's pretty sad.
On that note, thank you so much. I have learned so much today, and I have to say there's actually been a lot of validation for me in this episode. So thank you so much. Sorry I didn't want to cry, but it's been really validating. And I hope anyone else out there today has just had little moments of either going, I'm going to seek help, or I'm going to get my support network around me. Yeah. So, thank you.
Oh, thank you for having me.
Oh, I shouldn't end the show like this.
I know.
What a bloody mess I am.
I thought we're ending with a stare.
Oh.
I know. I want to be in on it.
For everyone, you need to go and watch the YouTube now because I'm getting cuddles from everyone. Oh, thank you.
Amazing.
I know. Thank you. No, but thank you so much. I've learned so much. It's been so good. Thank you.
You're amazing. You're doing incredible work. You are. You
Oh, thanks, love.
No, seriously.
Oh, it's bigger than me. It's not
is.
about me.
It's your legacy, though.
I was going to say legacy. Legacy. That's what it is,
So now that I've composed myself, I'll say a proper thank you, Dr. Edna. We have loved having you on today.
Thank you so much.
Yeah.
The on mic and the off mic chats have been wonderful.
The off mic, stay off mic.
Yeah.
So what happens at home
Stays at home.
This podcast represents the opinions of our hosts and their guest speakers. Views and opinions expressed in the podcast are our own and do not represent that of our places of work. This podcast is for informational purposes only, and content here should not be taken as medical or professional advice. Please consult your healthcare professional for any personal recommendations and medical care. While we make every effort to ensure that the information we are sharing is accurate based on the best available information at the time of recording, we welcome any comments, suggestions or feedback via our website contact form, home.com.au/contact. Names and details of personal experiences may have been changed to allow for anonymity and privacy. To join the conversation, join us on social media at Home Postpartum.